Radiology, and Dr. Ruwan Vijayasuriya, Consultant General Surgeon. Over to you, sirs.
Good morning, everyone. Let me invite the first speaker, Dr. Jeevani Udupihilla, Consultant Radiologist, University Radiology Department, Teaching Hospital, Peradeniya, to talk on radiological definitions and what to look for in imaging. Jeevani.
Thank you, Dr. Ruwan. Okay, good morning, everybody. So I will discuss the radiological definition and what to look for in imaging in borderline resectable and locally advanced pancreatic cancers. So next couple of weeks I will talk about the radiological definition of borderline tumors, imaging modalities to assess the pancreatic tumors, and imaging findings of borderline tumors. So in the absence of distant metastasis, pancreatic malignancies can be divided into three categories, that is resectable pancreatic tumors, borderline resectable, and locally advanced or unresectable pancreatic tumors. So the borderline pancreatic, the resectable tumors is a continuum between the resectable and locally advanced unresectable disease. There are many different classifications depending on the vascular involvement. So most commonly used, the guidelines we use is a National Comprehensive Cancer Network that uses a guideline. So the thing is, even though the tumor is technically resectable, the problem is most of the time the positive margins will be there after the surgery. So then the radiological staging is very important prior to the surgery. So the resectability depends on the vascular involvement. So arterial and venous involvement we consider. So when you consider the vascular involvement, you have to always check the tumor and the contact surface of the vessel. So abutment is if the tumor contacts less than half the circumference of the vessel, that is less than 180 degrees, we call it abutment. If it is more than the circumference of the vessel, that is more than 180 degrees of contact, we call it an encasement. Venous involvement is also like that, but only thing is veins are bit compressible, flexible. So they can get narrowed or displaced or stenosed, and contour deformities like the teardrop deformity and thrombosis, those are the venous involvement changes that we look in the imaging. So this diagram shows the tumor and the contact surface of the vessel. So if there's no contact surface, that is there's a clear flat plane is there, that is resectable, and there is no abutment or encasement. The second one shows there is a contact of tumor with the vessel, but it is less than the half the circumference. So if you see that less than the half the circumference, and then the more than the half the circumference contact, we call it encasement. Depending on the degree of encasement and type of vessel involvement, we can decide whether the tumor is resectable or borderline or unresectable. So always like you have to look for the anatomical variation, because that is very common place that you can get lot of anatomical variations in the arterial supply, like replace common hepatic artery, replace right hepatic artery, celiac artery and SMA as a common trunk, etc. So always look for any anatomical variation if you don't see the normal vascular anatomy. So this is the venous involvement, as I said earlier. So these veins are like flexible, they can like compress and they can displace, or they can encircle by the tumor. So first one shows there is no contact, so that is normal, and the second one there is a mild compression of the lateral aspect of the vein and it is displaced slightly. Other one shows there is a narrowing, and this fourth one there is a bilateral narrowing, and fourth one there is significant narrowing with collateral formation. Let's move to the guideline to assess the resectability, that is the NCCN guidelines. So when you see a tumor, first you have to see whether the tumor is in the pancreatic head, body or the tail. So when the tumor is in the, can I have a pointer? Okay. So the pancreatic head, the arteries that we consider, celiac axis, common hepatic artery and superior mesenteric artery. If there is no any contact with those arteries, arterial wise tumor is resectable. Same as the veins, if there is no any abutment to the main portal vein and superior mesenteric vein, then there is, that is clearly resectable. In the borderline resectable tumors in the pancreatic head, you have to look common hepatic artery abutment or encasement, but there are no extension to celiac axis or hepatic artery bifurcation, then it is resectable arterial wise. If it is less than half the circumference of contact with the superior mesenteric artery with no celiac axis encasement, again it is resectable. Veins wise, main portal vein and superior mesenteric encasement with reconstructible venous segment, or the less than 180 degree tumor contact with contour, irregularity or thrombosis with reconstructible venous segment, again it is borderline resectable tumor. So the non-resectable tumors, the more than half the circumference of superior mesenteric or celiac axis encasement or aortic invasion. And then there is no reconstructible segment in the superior mesenteric vein or main portal vein, again it is a unresectable tumor. So the body and tail region tumors, the arteries, there is no arterial contact with celiac axis, common hepatic artery or superior mesenteric artery, that is resectable. And same as the veins, if there is no any contact with the veins, then it is resectable. The borderline tumors in the body and the tail region, if the less than half the circumference of celiac axis or superior mesenteric artery contact, then it is borderline resectable tumor. And again, SMV and main portal vein involvement is there, but there is a reconstructible segment, then it is borderline resectable. And then the non-resectable tumors in the pancreatic body and tail, again, more than half the circumference of involvement in superior mesenteric or celiac axis, and unresectable, there is no constructible SMV or main portal vein involvement, again non-resectable. So those are the guidelines we follow. So preoperative imaging is very important. Why? Because you can say whether it's resectable, borderline or non-resectable. So that is to detect the tumor, characterize and for staging. So the CT is the very commonly used staging imaging modality, because it's a gold standard we consider, because it's widely available and it's very familiar to the surgeons as well compared to MRI. And we follow the dedicated pancreatic protocol, that is on contrast, late arterial, portal venous and the delayed. So the limitation is lack of sensitivity for identifying small hepatic and peritoneal metastasis. MRI, it is more sensitive in visualizing the small tumors, liver metastasis, peritoneal carcinomatosis and subtle signs of vascular infiltration. But the limitation is low spatial resolution compared to CT. And again we follow the pancreatic protocol. So this is endoscopic ultrasound. It's an excellent way of assessing pancreatic tumors, because same time we can get the tissue diagnosis as well, but the limitation is it is not freely available, and then you can't assess the distant metastasis. So PET CT, that we use to detect the metastasis in high risk patient and assessment of chemoradiation prior to surgery. So when you compare the CT and MRI, the good thing is CT positive predictive value is very closer to 100 for unresectability. But unfortunately, for the lower the predictive value for resectability, assessing it's closer to 80%. So again, CT is not very sensitive detecting focal vessel infiltration and the small liver mets. MRI is very sensitive in detecting liver mets, even small one we can detect. MRI is superior in detecting liver metastasis compared to CT. But the limitation is not freely available and it is costly. That is why most of the time we go with the CT imaging for staging. So how to work out when there is a pancreatic tumor? So first you have to see whether there is a tumor is there or not. If it is present, you have to localize whether the tumor is in the head or tail or body region. And then you check the resectability of the tumor. So that we have to assess the involvement of the vessels, arteries, veins, and the circumference of tumor contact, whether the tumor contact is there or not. If it is there, the degree of tumor contact with the vessel. So we will see few cases. So now you can see this is a pancreatic head adenocarcinoma. This orange arrow shows, and you can see the hepatic artery. Okay, hepatic artery. This is the dilated CBD, and this is the portal vein. So then there is the hepatic artery is well away from the tumor, and there is a portal vein. There is a clear fat plane is there, and the axial you can see the superior mesenteric artery, celiac artery, axis artery, clear of tumor. So this is the resectable tumor. So then this is the pancreatic head tumor again here, the green arrow, and then you can see the superior mesenteric vein. There is a clear flat plane between the tumor and the vein, and this is the portal vein, and you can see there is a tumor contact, but the contact is less than half the circumference of the vessel lumen. So again this is a resectable tumor. So this is a pancreatic body tumor. You can see this is the coronal plane, CT, pancreatic body tumor. Here you can see the portal vein. This is a superior mesenteric vein, and the tumor is in contact in the coronal plane. The axial plane you can see it is less than half the circumference, like 45 to 50 degrees in contact. So this is portal vein, and this is the axial coronal section. You can see the celiac axis and the SMA that is free of tumor. Again this is a resectable tumor, and this is a tumor in the body region you can see, and this is a superior mesenteric vein. There is a normal pancreatic tissue in between. Again there is no contact with the superior mesenteric vein, and then again the portal vein away from the tumor, and again this is venous wise it is a resectable. So this is another pancreatic body tumor. You can see there is an encasement of the tumor, narrowing of the lumen of the hepatic artery, but there is no extension to the celiac axis. And again you can see here there is no venous involvement. Okay, so this is a borderline resectable tumor because there is no extension into the celiac axis region. So this is the venous involvement. You can see there is a partial thrombosis of the tumor, and this is a complete thrombosis of the superior mesenteric vein. So this is by assessing whether it is there a reconstructible segment is there. If that's there, then you can go for a surgery. That is a borderline resectable tumor. Okay, this is the tumor. You can see this is a pancreatic head tumor. Then you can see it is encased in the hepatic artery and extending towards the celiac axis. Okay, so this is a unresectable tumor. So this is a tumor with multiple liver mets. Okay, this is out of surgery. Again, this is unresectable tumor. So these are some of the anatomical variants that you can see in that area. So make sure you have to apply the same theory to these anatomical variants as well. Whether there is a abundant encasement is there or not. Depending on the findings, you can categorize into resectable, borderline resectable or unresectable tumors. So this is a special note that I want to say. If possible, you have to do the ERCP and stenting prior to pancreatic phase CT, because you know the stents, they can cause artifacts. Then it's difficult to assess the vascular involvement. Other thing is after ERCP there may be some post-inflammatory changes that will also give some wrong impression about the resectability of the tumor. If possible, please do the CT, dedicated pancreatic protocol, prior to stenting. So the take-home message is CT and MRI has similar sensitivities and specificities for both diagnosis and vascular involvement in patients with pancreatic cancer. But the limitation is the cost and unavailability. And CT and MRI equivalent for local staging. But the MRI is superior to CT in detecting liver metastasis. So these are my references. Okay. Thank you. So I think the session is at the end.
Thank you, Jeevani. We'll take up the questions at the end of the session. So let's move on to the next topic. To share his experience and his view on evidence for complex pancreatic surgery, planning and outcomes, let me invite Nicholas Chatsakaris, consultant hepatobiliary and pancreatic surgeon from Queen Elizabeth Hospital, Birmingham, United Kingdom. Over to you, Nicholas.
Good morning, Mr. Chairman, ladies and gentlemen, dear colleagues. I'm humbled to be here in front of you. And today my talk is about evidence in complex pancreatic surgery. And the introduction by my colleague on radiology of these disease was making my job a bit easier. So for the purpose of the talk, I'm going to use the NCCN guidelines, and you can see here the latest version of them from 2023. And you can see that complex pancreatic surgery really refers to borderline resectable and locally advanced pancreatic cancer. As surgeons, we usually try to avoid the term unresectable, and I have a few examples later. And based on the guidelines, the patients go for neoadjuvant treatment, either chemotherapy or chemoradiation, and then for both stages, the resection is there in the pathway if technically possible. And these are the European, the ESMO guidelines that they have been updated in September 2023, which show the same pathway for this disease. I'm sure a lot of you have been in panels, in MDT discussions or discussions with your colleagues, oncology or surgeons, and the real question is it worth it? Is there a survival benefit? So one of our junior fellows has done this systematic review back in 2020 on all the evidence until that point on locally advanced pancreatic cancer. There were quite a few series, about 200-300 patients in total, and you can see the results there. Quite good oncological outcomes, 30-month median overall survival, which was almost 2.5 longer than patients that they did not receive surgery. So the conclusion was that surgery after neoadjuvant treatment is beneficial. It confers a survival advantage in selected cases of locally advanced pancreatic cancer. So how do we select the cases? We select the cases through the neoadjuvant treatment pathway. On the right side of the slide, you can see the various ways of delivering this pathway, whether it is chemotherapy only or chemotherapy followed by chemoradiotherapy. We can do it as a sandwich around the surgery or all up front as a total neoadjuvant approach. And then we select the patient and the disease. So patient selection is based on every unit's different protocols. I won't go at all into all that. The disease biology is assessed though by radiological evidence and CA 1999. And we always have to keep in mind that about 20% or so of the tumors will not secrete 1999, but in the rest of them, what we want to see is a downward trend. And there is evidence, there are studies that if the 1999 returns to normal, this is the subset of patients that they have better oncological outcomes. If it remains stable, or even worse, if it starts increasing, then the patients do not have good outcomes. The radiological stage has been very well analyzed by my previous presenter, by my colleague, but what I want to bring into your attention is that what the CT shows is not the same as the pathological stage of the disease. I will show you a few examples a bit later on. And the last one where we assess is operability. So can we technically remove the tumor? And it's not only the technical expertise of the surgeon, but it's also of the wider team, your scrub nurses, your anesthetists, the ICU doctors that they will look after the patient in the first few days where things are a bit more tricky. So complex pancreatic surgery is surgery on arteries and veins. And there's clear evidence now that vein resection is beneficial and is really considered a standard in pancreatic surgery. I've put up there a few papers. I won't go at all into the simple vein resections. But what about unresectable venous involvement? This is again the NCCN guidelines. Unreconstructable vein disease is considered locally advanced. They don't call it unresectable because again there are a few tricks around it. So SMV branch involvement, is it always unresectable? And the answer is no, it's not always unresectable. There are cases where we can resect either of the two major branches of the superior mesenteric vein and reconstruct them, or do not reconstruct them at all. We can leave the small bowel outflow on one branch, and then especially if the inferior mesenteric vein is draining in the splenic, it will take on the extra venous outflow and it will not be a problem. If we do want to reconstruct it, we have to be very careful. These are very thin veins, use very fine sutures, absolutely no tension. Most likely you will need an interposition graft. This is a schematic representation of what I just mentioned. So ileal branch or jejunal branch can be resected, not reconstructed, especially if the IMV is going into the splenic, or in a C diagram you can reconstruct it. And this is an actual case. So the tumor was in the uncinate process. It was very stuck on the ileal vein. We had to resect that. The jejunal vein here was not very developed, so we had to reconstruct the branch in the root of the mesentery. This is another example where the tumor was involving both branches at the very close proximity to the SMV. So we took control of both of them, resected both of them, and this is an interposition pantaloon graft. It's a cadaveric iliac vein, and you can see here that the splenic vein was also anastomosed in the graft to have outflow from the spleen after the Whipple procedure. This is another case of conventionally unresectable disease. You can see here portal vein going down. If you follow the slides, it disappears. These are varices from the pancreatic or duodenal veins and left gastric. These are all varices around the pancreas. These are all varices next to just where the SMV is reconstructed or reconstituted. So conventionally unresectable disease, but there is a trick around it. And this is a use of a temporary mesocaval shunt. So we start the dissection in the inferior border of the pancreas. We isolate and circle sloop the SMV there. In order to do that, we usually have to take one of the or two pancreatic or duodenal veins that they are variceal, ligate them. Then you take an interposition graft end to end on the superior mesenteric vein. You can ligate it. It's already thrombosed upstream. It won't cause any problem. Swing it down and plumb it onto the cava. Carry on doing your resection. The liver will continue getting a bit of portal flow through the collaterals until you take them all down, and then will survive only on the hepatic artery. At the end of the resection, take the cava anastomosis down, swing it up, and restore the portal flow in the liver. And I have for you here the pathology. So clearly on the radiological stage was a T4 tumor, locally advanced. Pathological stage after neoadjuvant treatment, T1C N0. So over the last 6 years, we've done 6 cases like this. We used that trick for 6 cases in Queen Elizabeth, exactly as I just explained the technique. Quite good median length of stay. 2 patients had severe complications. Overall survival, 33 months. These patients wouldn't have survived more than 12 months without surgery. So this is one of the indications of the temporary mesocaval shunt. There are only about 24 or so patients in the literature in mainly 2 large series that at least last time I checked, which was about a year ago, and they describe when to use it. One of these cases is that. The other one is getting access to the SMA if you have a complete vein thrombosis and a frozen area there in your surgery. And that brings us very well into how we deal with arteries. So arterial technique is mainly about 2 options. Periadventitial dissection or divestment, as it's called in the literature a lot of times, or arterial resection. And you can see the diagrams, the difference in periadventitial dissection versus the other techniques of transecting the mesopancreas. So it's about the SMA in this slide. More traditional technique, not very oncologically sound. Total mesopancreas resection, where you take the whole mesopancreas. Mesopancreas is not a defined anatomical space. It's basically whatever is contained in the space between the uncinate process, the vein, and the artery. And the periadventitial dissection, which is a technique that has been developed for borderline and locally advanced pancreatic cancer. And in addition to the total mesopancreas resection, you add the adventitial sheath of the periadventitial sheath of the SMA. That sheath is made of lymphatics and nerves, and it's a very good substrate for cancer cells to grow in that. It's very rarely that we see cancer invading the arterial wall. So we can basically strip the artery from its sheath as long as it's technically possible for as many degrees as we want, for as much length as we want, and I have a few examples. Now, theoretical risks in the literature are about bleeding, difficult to control because you're operating on the SMA, postoperative diarrhea because we denervate the small bowel, and a chyle leak. However, retrospective evidence do not suggest that the risks are more increased than the standard approach. However, the evidence do suggest that we get a better lymph node yield and better rates of local recurrence. We have this trial for the last couple of years in Queen Elizabeth where we check the effect of the periadventitial SMA, periadventitial dissection on the SMA for resectable cases of the disease. We're about 80% underway. So hopefully by your next meeting I may have a bit more outcomes. This is a couple of pictures. On the left, you can see the standard technique. You can see the lymphonural tissue around the SMA. Well, on the right, you can see the SMA completely stripped. You can see the white of the adventitia. And this is the example of the periadventitial dissection. We're coming down now to the arterial resection. So a bit more risky operations. The review from Heinz et al. In 2020 gathered all the studies on right-sided tumors on the head and neck. And as you can see, there are not many cases. Only 2 studies had more than 100 patients. And if we want to sum up the outcomes, we have acceptable mortality, we have a higher morbidity, higher severe grade complications, and a median overall survival of 17 months, which wouldn't be as long as we would expect it to be. That probably reflects the different stages of the tumors that were included in these studies. This is on the left-sided tumors, distal pancreatectomy versus modified Appleby. And again, the results are pretty much the same. Comparable morbidity, higher mortality, worse oncological outcomes in terms of 3-year overall survival. Now, Heidelberg Group, one of the biggest groups in the world, have published this in a paper in 2022. It's their experience on how to deal with arteries, comparing results between periadventitial dissection, or divestment as they call it, and arterial resection. As you can see, the results with the periadventitial dissection are a bit better in terms of oncological outcomes. Again, probably reflecting the disease pathology and the disease biology and the stage. On the right side, what's also very important is they published their experience with regards to the reduction in the mortality probability as the experience of the surgeon increases. And you can see how high it is initially. It's about 37%, but when you hit about 12 to 15 cases, it drops down to 10%, and then surgeons become a bit more confident, maybe a bit more cocky. They take on more complex cases, and then starts rising again. So we've done 16 arterial resections for the last 6 years. Half of them, we did not need a reconstructions. I have a few examples for you later. You can see the various case mix there. We had 3 postoperative deaths, 1 from surgical complication, 2 from medical complications over the first 48 hours. You can see how the pathology is. You would expect all these tumors to be at least T3, T4, but more than half of them, pathologically, they were T1 and T2. In 2 cases, there were even no negative disease. This is the overall survival for our cohort, small cohort, but 30-month overall survival. That probably reflects a bit of a more strict selection and staging with regards to which patient goes ahead and has the benefit of a surgical resection. Median overall survival, 21 months. So this would be a few suggestions for me when you think about attacking arteries. So radiological involvement on the scans is not the same as the pathological involvement. I'll have a few more examples for you. Always prepare for a vein resection. If an artery is involved, most likely you'll need a vein. Primary approach is always periadventitial dissection. It's always divestment. If you cannot do that, have a plan if you want to do an arterial resection. An aberrant right hepatic artery can often be sacrificed. As you know, you can take it if there's backflow, if there's liver Doppler signal in the hilum, it means you have enough collateral, so you do not need to reconstruct. We'll talk about a bit of the role of the left gastric artery, and I understand that lots of you do gastric surgery as well, so you're more experienced in that than me, but I have one slide about that. If we do an arterial resection and a reconstruction, always think about doing a total pancreatectomy. The reason is you eliminate the risk of a leak. The leak is the major risk for a post-pancreatectomy hemorrhage, and hemorrhage is the main risk of mortality for these cases. So eliminate that risk for your patients. If we do an arterial reconstruction, there are various methods to reconstruct. End-to-end is easy, it's preferred, but very rarely we get enough length to do a primary reconstruction without tension. Native vessels to be used are much preferable. In our unit, we like a lot the splenic artery transposition or an interposition graft. And then think about different tricks, and the temporary mesocaval shunt is one of them that can give access to the SMA if you can't get to it with the conventional methods. So the left gastric artery has its own role in pancreatic surgery. Modified Appleby is resected as a standard. In extended pancreatic or duodenectomies, you can take it. In the total pancreatectomies, it should be preserved as it's the main vessel that feeds the stomach. So if you have large tumors of the body, of the pancreas or the neck, start the dissection from there. If you can't get it, it's not bad to abort. Otherwise, you may end up doing a foregut resection, so adding in your total pancreatectomy, a subtotal gastrectomy. Reconstructing it is quite risky because it's a small vessel. There's a high risk of thrombosis, and it won't happen during your operation. It will probably happen 24 to 36 hours later when the SIRS response is higher in the intensive care. If you do a total pancreatectomy for non-oncological reasons, so if you do a common hepatic artery resection and reconstruction and you take out the pancreas to remove the risk of a fistula, you can preserve the splenic artery and the left gastroepiploic arcade, and then you can feed the stomach through that. If I have a bit more time, I can continue, or I can stop here.
I think we are past time.
Okay.
Thank you.
Thank you.
Thank you, Nicholas. Next speaker is Professor Igor Kachkov to talk on surgical techniques. Igor is from the Moscow State University of Medicine and Dentistry in Russia. Over to you, Igor.
That. So, dear Chairman, dear colleagues, thank you very much for the invitation. It's a pleasure for me to be here, and I would like to say many thanks to the organization committee for this hospitality that I feel here. And I also want to say many thanks to the previous speakers, because they said a lot from my topic and from these things that I also want to present. But I think that it's simply a reality, because we all think in one way and think what to do. So I'll try to show, I'll try to do it very briefly, our vision and our experience in treatment of advanced pancreatic cancer. So I would like to start that for today it's most untreatable cancer. You see how low is the progress in long-term survival in pancreatic cancer comparing with other types of cancer. So you see that according to the data of SIRS data, the 5-year survival for all stages only 12%, and I would like to pay your attention that if the patient suitable for surgery, the survival is increasing up to 17%. So the main reason for it is late diagnosis, and in these cases, in these circumstances, we should know how to treat these patients with advanced tumors. Of course, our treatment is based on this classification, which was mentioned in the previous reports, and in general, it's some illustration for it. And in general, you should understand that borderline resectable is the involvement of the vessel less than of 180 degrees in circumference. It may be hepatic artery or supramesenteric artery, and what concerning advanced pancreatic cancer, it's also the definition provided by NCCN, and you see it's more than 180 degrees involvement of the arteries, of veins, or an unresectable, unreconstructible involvement of portomesenteric segment. So based on these definitions, there are recommendations that also have been mentioned in the previous talk, and we know that if we have the patient with borderline resectable cancer or locally advanced cancer, we should start with chemotherapy, and it's usually FOLFIRINOX or gemcitabine schemes, or it may be some additional schemes based on positive genetic testing in BRCA1, BRCA2 mutations, and some others. And sometimes we have very good results, and it also very clearly shown in the previous talk. Here you can see the images of for example, of the female who received, you see several courses of FOLFIRINOX and 4 courses of gemcitabine, and we had complete response for this treatment. So we had a short study in our hospital in order to compare the tissues that we have for these patients who had and didn't have neoadjuvant chemotherapy. And you see how different is the tissue, which is para-tumor tissue. So, and the absence, there is also the difference in, in the fibrosis score in this case, and it was statistically significant. Of course, it provides more technical difficulties for surgery, and you see that, for example, in our cases, the blood loss was a little bit higher in the in patients with preoperative chemotherapy, but there were no differences in regarding R0 rates after surgery. The other thing that you should keep in mind when you take the patient with borderline resectable local advanced cancer for the operation after chemotherapy, after neoadjuvant chemotherapy, is that the response may be different, and you could suppose that some of the tumor parts can be localized in this fibrotic tissue, which may be or inside the tumor or in the peritumoral space. So you should plan your resection very carefully, and it should be extended as much as possible, because there are clear evidence that the R0 rates increase the overall survival and disease-free survival also. So what concerning arterial resections during pancreatic duodenectomies, for today it's also clear evidence that when it is possible, arterial resection could be done, and they also increase overall survival for these patients. The only thing that you should keep in mind that this resection should be done only in high volume specialized centers. And also it was very well shown in the previous report that when it is possible, you can do not only, yes, and these results also confirmed in the systematic review which was published recently, and it is based on 16 cohort studies, and you see that arterial resection, they increase the survival, and I just said about this. So here is the standard view of one of the operation after arterial resection and superior mesenteric vein also resection. And again, based on the preoperative examination, you could think in such cases not only about arterial resections, but also about artery divestment. You see, if you examine preoperative CT scans and MRI images together with endoscopic ultrasound results, you could suppose that the artery wall is not involved at the fully to the tumor, so you can plan arterial divestment, and there is a lot of data in the literature that such technique doesn't compromise the oncological results for these patients. So here I would like to show some videos from our laparoscopic approaches to borderline resectable tumors, and the technique is very important. It is very important to find the vessels in their healthy parts, as it here, to control the vessel fully, and then you start the resection, and you see that in laparoscopic, but we don't vote for laparoscopic or total laparoscopic or robotic approach. You should choose the technique that is most common for you and most in which you are most experienced. So here is the suturing of the example of the tangential resection, and here is the local advanced cancer. You see that the vessel is involved more in the circumference more than 180 degrees, and again you control it in healthy parts, and here may be technical difficulties when you mobilize the proximal part of the superior mesenteric vein. You could see it here. So in such cases, the mobilization of the mesentery, of the jejunum, of the intestinum, and transverse colon can help to mobilize and more, and to get more. I'm sorry, so to decrease the tension of the vessel. So you see that again, the laparoscopic approach provides all the possibilities for such type of the procedure. Here is a little bit more complicated case. It's the tumor of the body of the pancreas, and with this involvement of the celiac axis. And in this case, again, you should control the vessels in their healthy parts, like it is. You can see it here, and here we need to change the plan during the operation, because we're supposed to make the incision of the portal vein and to take off the trump, but the adhesions inside the vein were much more severe than we have expected. And you see here we didn't control the posterior branch of the portal vein, so we had some bleeding during this manipulation. But if you have good team, you can overcome all these difficulties. So total blood loss during this operation was about 800 millimeters, and post-operative period was uneventful. But we need to change the plan and also to put the artificial graft here. And you see again that even in such quite difficult circumstances, you can use the technique. Again, I want to emphasize that we don't think that we need to use laparoscopy here, but it could be used here. So, and you will see that the post-operative view of the operating field is absolutely the same like after open surgery. So here is our technique. Again, you could see that we control the vessels in the healthy part. Then you do everything here. You should think about the mobilization of the posterior part of the vessel, and we start the suturing from the one part of the world. Usually it's from this side, from the left, from the surgeon. Then use the 5-0 prolin and fix the knot on the opposite side on diameter, and then finish it with the suturing, with the continuous suture of the anterior wall. And here is the example of the growing of the tumor to the celiac axis. You see how it looks in the CT scan, preoperative CT scan. And again, if you find the vessel in the healthy parts, here common hepatic artery, you control it. You should make in such cases we make the intraoperative ultrasound to be sure that the blood supply of the liver is not damaged. Here is the origin of celiac trunk. Here is the ultrasound examination of the blood supply of the liver. And after that, after you understand that everything is okay, you can resect the celiac trunk. Here is clipping of it, and the final view of the operation. Here it is. So all this data, all the data that we have, all the results in this, in the treatment of these kind of patients, are summarized in the international consensus, which took place last year in Pisa, and it was published in Annals of Surgery recently. And the things that I would like simply to summarize them, I would like to emphasize that it is very important pre-operatively examine CT scans, MRI images, the results of endoscopic ultrasound, together perhaps with the specialists who do these examinations. And it is very important to keep in mind the level of CA-99, because although it is not suitable for all patients, but it is very important to assess it when you assess the response to the preoperative chemotherapy. So the main conclusion of this consensus is that the surgery after neoadjuvant therapy, if we have good biological response, is suitable, and the patient, and it is improving overall survival for these patients. And there is a place for some laparoscopic procedures and robotic procedures for borderline resectable cancer, and it should be doubtful. It is doubtful for local advanced cancer. So, if summarize all these recommendations, and I would like to say, and speaking about surgical technique, I would like to say that the surgeon should understand that he will work in different conditions, in abnormal anatomy, and it will be difficulties in understanding of proper layers and margins. And these circumstances, you should carefully study all the preoperative CT and MRI images, and you should start your surgery with the finding of healthy parts of main vessels and move right along the wall of the vessel, because it's a sort of vascular surgery, and you should be very experienced in vascular surgery. And if you are not have such possibilities, you should invite vascular surgery for such operation in order to make them safety. And in all cases, it's teamwork. So here is our pancreatic team, part of our clinical team, and thank you for your attention.
Thank you, Professor Igor. Let's move on to our last speaker. Let me invite Professor Sulochana Vijayasuriya, Consultant Pathologist, University Pathology Unit, Teaching Hospital, Peradeniya, to share her experience on processing the specimen for frozen sections. Thank you.
Thank you for that introduction, and also thank you for inviting me to share my experiences in the pancreatic resection specimens. So basically this would be, I will be mostly touching on the practical aspects, right? So this, in surgical pathology, the pancreaticoduodenectomies are one of the most complicated standard specimens that we receive. So these are the types of specimens that we commonly receive. And what you expect from the histopathological evaluation. Mainly the two most important things that the surgeon wants to know are the pathological staging and the resection margin status, right? And then there are other things. So for these two, the correct pathological staging and the resection margin status evaluation, both the surgeon, the way the specimen is sent to the pathologist, and the way the specimen is handled by the pathologist, both are very crucial. Right. So for reporting, universally we use these synoptic reporting systems. So where there is this standardized way, the minimal data sets that we have to follow. There's a standardized sampling handling guidelines, and also there's a checklist of all clinically relevant histopathological information that we should provide. So there will be no the overlooking, right? And also there will be consistency in reporting throughout the world. And the commonly used minimal data sets are what is prepared by the Royal College of Pathologists and the AJCC and the Royal College of Pathologists in Australasia. So we mostly use either the RC guidelines or the AJCC guideline. All of these are more or less the same with very minor variations. Right. So few general instructions, not only for the pancreaticoduodenectomies, but more relevant to this. So you have to send the specimen in the best possible way, right, so that we will be able to identify the anatomy and the margins, right? And it is important you put it in a formaldehyde spacious container and send immediately. Why? Although you have put it in a fixative, important to send it immediately. One reason is with fixation there is the anatomy changes, right? And once there is too much fixation, it's very difficult to identify the margins and the anatomical features. The other one is with fixation the tissue shrinks, right? So the tissue shrinks and then the margins become closer to the tumor as it really is, right? So you have to send it immediately. And the other reason is formalin penetration is slow, and if we delay the sampling, the center would be autolyzed. And also if there's anything specific, you have to mark then the label it. You should not leave anything to the imagination of the pathologist. There can be a lot of miscommunication if you do that. Right, so this is what I told you, especially in a pancreaticoduodenectomy, especially if there is a delay, right? You have to better to put some sutures if the specimen is not standard, right? If it's a just very standard specimen, we will be able to identify. But if there's anything, the difficult surgery and the anatomical landmarks are not very clear, always put labels and send, so that you are assured that you will get a better report of the margins, especially, right? So what we do is we color it, right? We have color codes for the neck resection, the vein and the artery, and then we perpendicularly serially slice it, right? So and then we sampled accordingly. Here you can see the tumor almost abutting the superior mesenteric artery margin, right? So it's clearly we can take the margins, right? So this is a pancreaticoduodenectomy specimen, and when it's take the subtotal pancreatectomy, the most important margins are the anterior, posterior and the resection margins. So this is pancreatic pseudo papillary tumor, and then occasionally we can get ampulectomies, especially for benign tumors in the ampulla. Now in this situation, especially if it is a benign tumor resection, the orientation is extremely important, because there is no way we will be able to orientate the specimen. So it is better to send it attached to the board with correct orientation, so we know exactly what we are looking at and which margins we are looking at. So most importantly, the resection margin status, whether it's R0 or R1. So this is a very important piece of text that I found in a review paper. Because resection margin involvement is generally believed to be determined by the quality of the surgery, a low R1 rate is often seen as an indicator of high quality surgery. Recent studies, however, have brought the pathologist as a second player of the field, based on the growing awareness that standardization and meticulousness of the pathological examination have a significant impact on the accuracy of the reported RM status. The R1 rate is therefore a performance of measure not only for the surgeon but possibly also for the reporting pathology. So that is why it's so important that the surgeon and pathology team has a very good understanding and a good communication with labeling, and that is the mantra. And again, send the specimen as quickly as possible. And in Sri Lankan setup, we know it's a very common thing that we are sort of handling so many surgeries at a day, right? And the specimens get stagnant in the theatre, and sometimes we get the specimen 2 or 3 days after. So in that sort of situation, all the anatomy is distorted, center is autolyzed, and that's a nightmare for the pathologist. Right. So the second the aspect is the intraoperative consultations. So mostly intraoperative consultations are done to assess the resection margins, and the sample should be sent fresh. And it is advisable to maintain the diagnostic time under 20 minutes. Now in our center, I think it's about around 10 to 15 minutes. What are the steps? So first, it's done in a very quick manner, right? And so you have to make sure there's no chaos in the process and it operates in a smooth way, right? And again, especially in our setup, the supporting team is not very familiar with the intraoperative diagnosis process. So the training of the team, the non-medical team, also very important, right? So first you have to inform the pathologist and make the appointment. and also provide the necessary clinical information, and especially the radiology and the intraoperative findings, right? And the specimen should be sent to the lab in the speediest possible way, and very importantly with a responsible person. Again, I am talking about the Sri Lankan context. This is the stage I am mostly nervous about, sending the specimen. So not infrequently what we encounter that so the surgeon delegate the responsibility to the house officer delegate it to a laborer in the lab, right? So they don't know like the importance of taking them as quickly as possible. Sometimes, so when the specimens get delayed, I start harassing the surgeon like to make sure it's coming. And once it got so delayed, and they have sent it from there and to see, and then I found that in the lab far corner, the orderly sitting nicely, comfortably, and to see she's the one who has brought the specimen, and so she has not been trained. You can't blame the person. The person has not been trained to do that. So make sure that it is done by a trained person, responsible person. And also you have to keep your phone on, because in the theater most of the time the signals are not working well. So you should be contactable as soon as we make the diagnosis. So the ways that we do frozen sections, that is the histology method. So again, it is cut in a frozen so where we receive the specimen and snap freeze with liquid nitrogen and cut it with the frozen microtome. And there the frozen microtome has to be sort of ready. It has to be, we have to bring it to that particular temperature. So that is another reason why these things we have to prepare, right? And then the tissue imprint, that is you take the fresh tissue and make some imprints on the slides and fix it with 95% alcohol and look at it. Usually for all frozen section, we do both methods. So in intraoperative diagnosis in general, anywhere in the world, the resection margin status of pancreatic resections are the most challenging, right? That is because one thing is histologically, these pancreatic tumors, although they are biologically aggressive, they are not histologically very aggressive looking, right? So there can be so many mimics, especially chronic pancreatitis can mimic sort of invasive pattern. So it's a very challenging diagnosis to make. That also we have to keep in mind, and therefore very important the radiological findings and the clinical information, especially the operative findings. So this is histological frozen section specimen, right? So you can see there, these are the tumor, invasive tumor, right? And this is a touch imprint of a neuroendocrine carcinoma of the pancreas. Nice. Thank you.
Thank you, Professor Sulachana Vijayatanga, for that informative talk. I would like to thank all the speakers for your contribution today. There won't be any time for questions, so we can conclude the session.
Ladies and gentlemen, that concludes the symposium on approach to borderline resectable and locally advanced pancreatic cancer. I cordially invite the chairpersons, Professor Rohan Sirivadana and Dr. Ruwan Vijayasurya, to award the certificates and token of appreciation to the resource persons. First of all, I cordially invite Dr. Jeevani Udupihille, Next, Professor Nicholas Chatzizakaris. Professor Sulochana Vijayatunga. And Professor Igor Katkov. Now, I cordially invite Dr. Buddhika Dasanayaka, Consultant General and Hepatopancreatobiliary Surgeon and Senior Lecturer in Department of Surgery, Faculty of Medicine, University of Peradeniya, to award certificates of appreciation to the chairpersons for their invaluable contributions. Professor Rohan Sirivardhana, Professor in Gastroenterology. And Dr. Ruan Vijay Surya, Consultant General Surgeon. Thank you, sir.
Ladies and gentlemen, we are excited to invite you to Dr. Noel Bartholomew Prize session, which will start shortly at the Peacock Hall in the first floor, followed by the Sark oration. Further, we encourage you to explore several exciting features of the event. Please visit the photography exhibition on the first floor and take a moment to check out the trade stalls and the photography booth, which is curated for live members, which is on this floor. Please make arrangements to return to this hall by 12 noon to ensure a timely start of the next symposium. Thank you, and we look forward to your participation.